Learn the 2 key clues that point to the next best test in resistant hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 31-year-old woman is evaluated at a rural outpatient clinic for blood pressure that remains above goal, despite confirmed adherence to 3 antihypertensive agents. Pharmacy refill records and pill counts at 2 prior visits verify daily use of lisinopril 20 mg, amlodipine 10 mg, and chlorthalidone 25 mg. She also takes naproxen 440 mg as needed for osteoarthritis several times per week and methimazole 5 mg daily for recurrent Graves' disease. She does not smoke or drink alcohol. Over the last 4 months, she has developed muscle cramps, intermittent headaches, and increased nocturia. Temperature is 36.3 degrees Celsius, pulse 85 per minute, respiration 17 per minute, blood pressure 148/80 millimeters of mercury in both arms while seated, oxygen saturation 97% on room air, and body mass index 28 kilograms per square meter. Cardiopulmonary examination is normal. No abdominal bruits are heard. There is 1+ bilateral pretibial edema. The thyroid is normal in size without tenderness, and the skin shows no striae or easy bruising. Laboratory studies show sodium 146 millimoles per liter, potassium 2.9 millimoles per liter, chloride 103 millimoles per liter, bicarbonate 30 millimoles per liter, blood urea nitrogen 20 milligrams per deciliter, creatinine 1.4 milligrams per deciliter, glucose 92 milligrams per deciliter, and 24-hour urinary potassium excretion 72 millimoles. Urinalysis shows specific gravity 1.014 and no protein. Morning cortisol after an overnight 1 mg dexamethasone suppression test is 0.6 micrograms per deciliter, and thyroid-stimulating hormone is 1.8 micro-international units per milliliter. Abdominal ultrasonography performed locally last month showed normal-sized kidneys without hydronephrosis and no adrenal mass. Computed tomographic angiography was avoided because she develops flushing after iodinated contrast. A 12-lead electrocardiogram and chest radiograph are unremarkable. Advanced imaging and subspecialty services are not easily accessible in this rural setting. Which single diagnostic test is most appropriate now to identify the specific secondary cause of her resistant hypertension? Option A. Renal artery duplex Doppler ultrasonography to assess renovascular hypertension. Option B. 24-hour urinary fractionated metanephrines to screen for catecholamine excess. Option C. Morning plasma aldosterone to renin ratio after adjusting interfering antihypertensive medications. Option D. Serum uric acid measurement to assess hyperuricemia-related hypertension. The correct answer is option C, morning plasma aldosterone to renin ratio after adjusting interfering antihypertensive medications. The most likely specific secondary cause is primary aldosteronism, so the best next diagnostic test is a morning plasma aldosterone to renin ratio after adjusting interfering antihypertensive medications. The STEM is built around that pattern. Resistant hypertension on 3 drugs, hypokalemia to 2.9 millimoles per liter, metabolic alkalosis with bicarbonate 30 millimoles per liter, renal potassium wasting with 24-hour urine potassium 72 millimoles, and normal screening for other endocrine causes. Her dexamethasone suppression test is normal, and thyroid testing is normal, so Cushing syndrome and thyrotoxicosis are not the explanation. In a rural clinic, the aldosterone to renin ratio is also a high-yield, practical first step. Renal artery duplex ultrasonography is less appropriate because the vignette does not point most strongly to renovascular disease. She has no abdominal bruit, a young age that could raise fibromuscular dysplasia as a possibility, but the biochemical pattern much more strongly supports aldosterone excess. 24-hour urinary fractionated metanephrines are not the best next test because she lacks a catecholamine syndrome. There is no triad of episodic headache, palpitations, and diaphoresis, and her potassium findings would be unusual for pheochromocytoma. Serum uric acid does not identify a specific, treatable secondary cause of resistant hypertension. In summary, the correct answer is the aldosterone to renin ratio obtained after medication adjustment. Primary teaching point: resistant hypertension plus hypokalemic metabolic alkalosis should trigger screening for primary aldosteronism. Secondary teaching point: the best differentiating test is the one that fits both the biochemistry and the clinical setting, not the one that is merely available. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.